I'd like to start by extending my sincere thanks to the coordinators and sponsors of this meeting. It's a privilege to be able to speak with you tonight on the topic of the social and economic vulnerability of women. Really what I'd like to do tonight is start by giving a brief overview of some of the global burden of disease and transmission dynamics related to HIV globally and in the region. And then I'd like to spend really the majority of my time telling you a story about the collaborative work that I've had a privilege to be a part of here in the Caribbean, specifically in the Dominican Republic, and talk to you about a case study of an intervention model which we call Abriendo, Puertas, or opening doors. So first I'd like to start by reminding us all of the significant impact that the HIV epidemic has taken globally over the years. And as you can see here, over the course of the epidemic, there's been more than 71 million people who have been infected with HIV, and 34 million people have died. Today, there are currently 36.9 million living with the virus, and the majority of those are in sub-Saharan Africa, about 71%. In terms of global epidemic trends, we see that since 2010, about 2 million people are still being infected annually with HIV. And there's been no significant decline in the rate of new infections since that time. Of course, we've seen important and positive declines in AIDS-related mortality since 2005, approximately 45%, given important advances in ART access across regions. However, in 2015 alone, we saw 1.1 million AIDS-related deaths, signifying that we still have tremendous work to do, whereas less than half of those in need of treatment globally are receiving it. If we focus in on the Caribbean, we see that the region has the highest HIV prevalence outside of the sub-Saharan African region. And while subgroups such as men who have sex with men and drug users are certainly at heightened risk, heterosexual transmission continues to be the primary mode of transmission in the region. Additionally, it's the only region outside of sub-Saharan Africa where more than half of people living with HIV are women. Female sex work plays an important role in ongoing transmission dynamics in the region, and what you can see in this graphic here is the distribution or the percent of new infections per subgroup within the region. The top arrow, where you see 6% in blue, signifies the percent of new infections coming from female sex workers. But if you combine that with the clients and partners of female sex workers, you see that in total we're talking about 30% of all new infections in the region. Additionally, we need to pay attention to some concerning trends, whereas despite important gains and declines in incidence in previous decades, between 2010 and 2015, we actually saw an increase in HIV infections in the region of about 9% in the rate of new infections. In 2015 alone, it was estimated that 9,000 new infections occurred in the Caribbean region. Turning our attention to women, we observe that more than half of people living with HIV globally are indeed women, and HIV is the leading cause of death among women of reproductive age 15 to 49 years of age. A particular subgroup of women, young women and girls 15 to 24 years of age, account for a significant portion of new infections, new HIV infections, compared to their male counterparts. The vulnerability of women has multiple dimensions. The first is biological, whereas biologically women are twice as likely to become infected with HIV through unprotected heterosexual sex. And young women and girls are particularly biologically vulnerable. In addition to that, we see the social and structural dimensions of women's risk for HIV, and this is seen through the way in which inequitable gender norms, gender-based violence, discriminatory laws and policies, as well as unequal opportunity structures around access to education, jobs, and training impact women's ability to negotiate safer sex and to access HIV-related services. Female sex workers are among the groups of women at most dramatically increased risk for HIV. What you can see in this figure is that female sex workers overall globally have approximately a 12% prevalence of HIV. And this is really, it translates into an increased odds of almost 14 times that of women in the general population, meaning that female sex workers compared to other women are 14 times more likely to be living with HIV. And this dynamic of the dramatic distance between women in the general population and the risk of female sex workers is seen across regions. The highest, of course, in sub-Saharan Africa, followed by Eastern Europe, and about 6% prevalence among female sex workers in Latin America. Turning now to what we know about female sex workers and treatment as prevention, the literature has been growing over the last several years. About 5 years ago, our team at Johns Hopkins did an exercise, a mathematical modeling exercise, to show if we were able to actually achieve equitable access to ART for female sex workers, what would this translate into? And we saw that if we could do that and we could increase significantly the rate of viral suppression in female sex workers, we could not only improve their own individual health outcomes, but we could significantly decrease HIV incidence in the general population by intervening with female sex workers across epidemic settings. However, in reality, sex workers have significantly lower access to ART and lower adherence to ART than other women due to structural factors such as stigma, discrimination, violence, drug use, and financial insecurity. We continue to have limited epidemiologic data on the care continuum among sex workers, but the data we do have suggests that there's an estimated 57% of female sex workers who are virally suppressed, so still a long way to go to get to that third 90. Now I'd like to turn my attention to the Abriendo Puertas case study in the Dominican Republic. And this, as I mentioned, is a very collaborative effort which was led by a combination of community groups, research institutions, academic groups, and NGOs, including some folks who are here tonight from the Instituto Dermatológico de Cirugía de la Piel, and that is JC Donestor, Marta Perez. Jose Gomez is not with us. My colleague Claire Barrington from UNC is also here, and I want to recognize collaborators from Modemo, which is a sex worker rights organization in the Dominican Republic, as well as the NGO Cohort, who helped implement the intervention. So what I want to do is tell you a little bit about how and why this intervention started, and the initial process evaluation and initial effectiveness evaluation that we conducted, as well as some of the experiences of participants that have now informed the scale-up of the intervention in the DR. So our specific aims were to explore multi-level factors inhibiting optimal HIV outcomes among female sex workers living with HIV in the Dominican Republic, to then assess the feasibility and initial effects of a community-driven multi-level intervention model among this population on HIV outcomes, and then to document experiences in the intervention. So just to set the stage in terms of the setting in the Dominican Republic, the DR is a country of approximately 10 million people. It's estimated that between 60 and 100,000 women are female sex workers in the DR. Sex work is not illegal, however, stigma, discrimination, and violence are prevalent. If you look at the HIV prevalence overall in the DR, it's less than 1%, but the median national prevalence among female sex workers is over 4%, translating into a 6 times greater odds of living with HIV if you're a sex worker as opposed to women in the general population. Over the years, the DR has been recognized internationally for some best practices around HIV prevention among sex workers. There's been a lot of collaboration between community groups, as well as government agencies and academic partners, and several important models have been developed, like the Avancemos model, as well as the Compromiso Colectivo model. So we will overcome, collective commitment, all in the spirit of empowerment and solidarity. And you can see here this educational material, We Too Have Rights, in that same spirit. If you look at the trends in prevalence in the DR over the years, you see that in the early 90s, mathematical modeling was suggesting that we may have a generalized epidemic in the DR. But what happened actually was by the mid to late 1990s, the epidemic somewhat stabilized, and we actually started to see declines by the mid-2000s. And many would attribute these successes and these gains to the successes that we saw among key populations like female sex workers, where you see a dramatic decrease in the prevalence of HIV over the years. And this, again, due to some of the good work of NGOs and community groups in the DR, especially in big cities like Santo Domingo and Puerto Plata. Of course, outside of some of those bigger cities, we see more challenges and higher prevalence. Just to give you a little more sense of the context of female sex work in the DR, certainly there's a lot of diversity around sex work in the DR and throughout the Caribbean, whether it's female sex workers, male sex workers, trans sex workers. But some of the things that you do see in common is the need and the desire to have a livelihood that can support people as individuals as well as families. And particularly in the case of women, you see that the majority of women in the DR have children, they are mothers, and they're working hard to support those children, provide them with education, food, clothing, etc. Also in terms of the different modalities of sex work, you see that sex work might occur in brothels, bars, and discos, but it also occurs on the street as well as independently. So around 2011, building on some of the prior work that was conducted in the DR and these models of really kind of grassroots, community-driven responses, we wanted to see what was the next step, where were the gaps? And at this time, certainly the frame of treatment of prevention was coming on the radar, and we knew that while a lot of important work had been done, we hadn't really paid much attention to the needs of female sex workers living with HIV. We didn't really know a lot about what was going on with that subpopulation, and we didn't know much about their access or barriers to adherence. And so we started by conducting formative qualitative research during that time, including in-depth interviews, focus group discussions, and key informant interviews to really understand and identify those barriers to access to prevention and care services. And the first thing that we really started to understand is that stigma and discrimination in this population is multifaceted. Stigma, discrimination, and inequality is experienced by being a woman, by being poor often, by being a sex worker, and by living with HIV. And that all of those things are interacting in the daily lives of the participants that we spoke with. In addition to this intersectional stigma and discrimination, we found that there were challenges with mental health and substance use. There were issues around lack of social support, concerns around the quality of clinical care, as well as financial insecurity and challenges being able to pay to get to the clinic and other medical costs. So overall, there was definitely a pervasive sense of socioeconomic exclusion and a lack of social and material resources to be able to build and sustain health and well-being. In response to that, our team came together with Modema, with the sex worker rights organization, with this information that we gathered in formative research with participants to develop the Abriendo Puertas model. And it's a multi-level model that tries to attend to the barriers that I just mentioned at each of those levels, the individual level, the relational level, the environmental, and the structural. So at the individual level, looking at issues of internalized stigma, for example, or disclosure of status, acceptance of diagnosis, there are 6 individual counseling sessions that were developed as part of the model that would be implemented at the IDCP offices by a trained clinical psychologist or social worker. At the relational level, we then developed a system of navegadoras, or peer navigators, where other sex workers could provide support and actually facilitate access to care so that sex workers living with HIV weren't having that door closed when they got to the clinic. They weren't accepting when there were discriminatory statements or policies in place in the clinic. Instead, the navigators would help open that door for them and provide them with support that they needed to access care. They also made home visits and provided them with other forms of support as needed. At that environmental level, we trained clinical care providers in terms of sensitivity training and competencies and understanding the needs of female sex workers as a unique population, trained 40 providers. And then at that structural level, we tried to attend to something that the female sex workers would call financial insecurity. So it wasn't about just having a job, it was about how to manage money, and it was about making sure that they had diverse forms of income, for example, so they were interested in income generating activities. So we developed a series of casas abiertas, or open houses, where the women could come together and not only have social support and solidarity with each other, but they could learn practical skills to be able to generate income and make money and learn how to save money and manage the money that they were making. So together that formed the model that we were interested in evaluating, and I just want to talk a little bit now about how we evaluated the model. We used a longitudinal cohort study. We enrolled approximately 250 women into a cohort in Santo Domingo between 2012 and 2013. And each participant went through a structured survey and blood draw at both baseline and 10 months during this initial observation period. And at the end of the 10 months, we had about 90% retention, or 228 women. We also conducted a series of qualitative interviews and focus groups discussions to understand participant experiences in the intervention. These are just some characteristics of our participants in the cohort. Median age was about 36, a low level of education, generally 7 years. Most had regular partners and almost all had children, as I mentioned earlier. The median number of children was 3. A little more than half were street-based sex workers, as opposed to venues such as bars and brothels. About a quarter had reported prior drug use, and most had been in sex work for many years, 15 years, although we learned that many would come in and out of sex work depending upon different dynamics in their lives. The median number of years living with HIV was 5. And one interesting finding that was somewhat surprising to us was that almost 19% of the women in the cohort became sex workers after they learned of their HIV diagnosis. So many people think of the heightened risk of sex workers due to their occupation, but what we learned is that, unfortunately, especially due to discriminatory testing policies, HIV testing policies in the DR, many women, and not just women, but others in that setting, find it difficult to get a job after they're diagnosed with HIV because many employers have mandatory testing, even though that's illegal, and so they can't find other forms of work. So from our baseline findings, you can see here a picture of the HIV care continuum in our Abriendo Puertas cohort. So again, most of these women were already linked to care due to the way in which we recruited them initially. However, when you start moving down the care continuum, you see that engagement in care in the last 6 months is now 85%, only 72% were currently receiving ART at baseline, and then less than half were virally suppressed. So significant drop-off along the care continuum. So before really jumping into the full implementation of the model, we wanted to understand some of the dynamics around what factors were associated with detectable viral load and also what factors were associated with HIV treatment interruptions or stopping ART. And what we found was, again, younger women were more likely to have a detectable viral load, those who had used drugs in the past, and those who had interrupted ART at some point. So not just daily adherence, but a treatment break of sorts. We then looked a little more closely at this issue of ART treatment interruption, and there we saw that both internalized stigma related to sex work as well as enacted stigma or explicit discrimination, experiences of discrimination, were both related to breaks in treatment or treatment interruption. An additional set of factors that we learned were highly significantly related to HIV treatment outcomes at baseline were the issues of violence, both intimate partner violence as well as violence coming from clients. So here you can see that these different forms of violence are associated across the board with engagement in care, not being on ART, ever interrupting ART, or reported adherence. So again, substance use, violence, these were things that were jumping out, calling our attention as critical factors that needed to be attended to in the intervention. So turning now to the actual implementation of the intervention. First, a bit about feasibility and participation. So this gives you a sense of, at that 10-month follow-up visit, what was the level of engagement in the intervention. We see that over 90% of participants had completed all 6 individual level counseling sessions, and 61.7% had had contact with a peer navigator. Of interest, we also had kind of a sub-study, pilot study trying to offer testing to the male partners of sex workers, and by doing partner referral and offering testing, we found that 1/4 of the male regular partners of sex workers tested for HIV. So that's for future studies, but here was just a bit of a pilot. At the environmental level, again, we did the sensitivity training with clinical care providers, and then at the structural level, we saw about 50% of the women were participating in community mobilization activities such as those casas abiertas that I mentioned. In terms of changes in key HIV outcomes over that initial 10-month period, we saw significant changes in key behavioral outcomes, such as the percent of women who had received HIV care in the last 6 months. So at baseline, 85.5%, this jumping to 94.5% at follow-up. ART adherence, having no missed ART doses in the last 4 days, went from 72.5% at baseline to 88.8% at follow-up. And then on the prevention side, protected sex with all sexual partners, both clients and intimate partners, increased from 71.5% to 82.5%. So we saw these significant changes in behavioral outcomes during that 10-month period. When it comes to viral suppression, however, we did not observe significant changes from baseline to follow-up. It stayed at about 50% during that time. We then looked through multivariate regression at the effects of exposure to the intervention. So was there a dose response? Were those who were highly engaged with the intervention more likely to have better adherence to ART, for example, or greater protected sex? And indeed, we saw a significant relationship between high and moderate exposure to the intervention and both of those outcomes, both in terms of ART adherence and protected sex. What we also observed on the flip side was that alcohol and drug use were significantly inhibiting positive outcomes at follow-up, as you can see here. As I mentioned, in addition to the quantitative surveys, we also did qualitative work over the course of the intervention to really understand what was the experience of the women in the cohort with Abriendo Puertas. And I think one of the main themes that really jumped out was the theme of the power of solidarity to break down stigma and discrimination. So as this participant states, why would they be interested in a prostitute living with HIV? I used to feel that I was insignificant. However, I got a very good psychologist. When I came to see her, she gave me support. She energized me. And here at Modemo, I participated in the Casas Abiertas, and I learned to decorate sandals and make hair products and candles. And I thought to myself, but if I'm doing all of this, why can't I move forward? I came here and they changed my life because I was so depressed, I felt dirty, I felt isolated. So it just really speaks to the power of connection and the power of solidarity to break down some of these internalized experiences of stigma, as well as really to change some of the practical dynamics of people's lives when it comes to social and economic exclusion. So I want to mention a few limitations and challenges of this work. First, the initial evaluation of Abriendo Puertas was based on a non-randomized design, and we did not see significant changes in viral suppression in that initial observation period. The lack of significant change in viral suppression may be a result of suboptimal adherence or our ability to detect it with the reported measures we were using at that time, but it also may be a reflection of quality of care issues, including issues with appropriate regimens and resistance. And these are things that we're addressing in future research now by screening the blood for ART, for example, and testing for resistance. We also saw that substance use predicted the lack of viral suppression from baseline to follow-up, indicating the need to target substance users in future intervention research. So looking now at the research, policy, and program implications of this work, We feel that the barriers to achieving HIV outcomes among sex workers living with HIV are very much structural in nature, and they include sex work stigma and discrimination, violence, and substance use, as documented by some of the analyses I presented here. And these barriers can be partially addressed by psychosocial support and solidarity building activities through community mobilization and empowerment. But there are also changes in these structural factors in terms of government policies and services that are necessary. And in the scale-up of the Abriendo Puertas intervention, we're now focused on how do we implement and integrate this model into government clinics, into public clinics, not just in private research institutions and NGO clinics. And J.C. Donostor will be talking about that a little later in the conference. Additionally, we're also thinking about how to adapt this model to other key populations like transgender women and MSM, and Marta Perez will have a presentation on that. So trying to synthesize what we've learned to date from both the quantitative work and the qualitative work, as well as implementation of the intervention, we've developed a working conceptual and operational model of the socioeconomic determinants of HIV among sex workers, which you can see here, and it tries to lay out at these different levels, at the individual level, the relational level, the environmental and structural level, what are some of the factors that are affecting these key behavioral and biological outcomes, and how do we intervene on them to make sustainable change? So we're trying to document these pathways and also contextualize these pathways by paying attention to the legal and policy environment, that socioeconomic environment in which all these factors operate, ultimately with an eye towards increasing viral suppression. And we have the opportunity to build and learn from the work that we've been doing in the Dominican Republic, in the Caribbean, to inform global practice, to inform practice in other regions such as sub-Saharan Africa. There's always been a nice synergy in history of the work in the region informing these best practices, informing projects and intervention and research in other settings, and the Abriendo Puertas intervention is no exception. We have an NIH-funded project called Stigma, Cohesion, and HIV Outcomes in Vulnerable Women across geographic and epidemic settings, where we're taking that framework I just showed you, that socioeconomic determinants framework, and really testing it out and looking at how those different pathways operate across different cultural settings, across different epidemic settings. So, and in the context of community mobilization interventions led by sex workers themselves. So in the DR, it's Abriendo Puertas. In Tanzania, we have another project called Project Shikamana, which in Swahili means stick together. And again, it's similar community-based, human rights-driven interventions, and the women themselves are really defining the shape of how those interventions roll out. And as collaborators, we are helping document some of those processes and measure some of those dynamics around social cohesion and mobilization, and to ultimately be able to connect the dots between those structural factors and processes and the biological outcomes of interest, such as viral suppression, with an eye towards how might those same processes and that framework help us understand things like access to PrEP and adherence to PrEP. So with that, I want to thank you for being here and for allowing me the opportunity to share the Abriendo Puertas story with you all. I want to thank my collaborators who are here in the room from the DR, all of the study participants and the different NGO and governmental organizations from the DR that made this possible. Thanks so much.